Hey class, in this video we're going to be talking about chronic obstructive pulmonary disease. These are the learning objectives for the video. We're going to talk about the pathophysiology of COPD, risk factors for COPD, classic clinical presentation and how you diagnose it, and how you stratify patients and pick pharmacologic treatments for them, also how to manage a COPD exacerbation. So this is the technical definition of COPD. It's a heterogeneous lung condition characterized by chronic respiratory symptoms like dyspnea, cough, sputum production, and/or exacerbations due to abnormalities of the airways and/or alveoli that cause persistent, often progressive airflow obstruction. And it's caused by complex, cumulative, and dynamic gene-environment interactions over the lifetime that can damage the lungs. And manifests as emphysema or chronic bronchitis, and most patients have a mixture of both. So here are the risk factors for COPD. Obviously, tobacco smoking is the most common by far, especially in high-income countries. It's more than 70% of cases are attributed to tobacco use. But in lower-income countries, biomass exposure plays a bigger role. And so this is going to be household air pollution due to burning biomass in open fires or poorly functioning stoves. You also want to think about occupational exposures like dust, chemical agents, and fumes, and then regular air pollution, genetic factors. And then also poor lung development, low birth weight, and prematurity are risk factors for COPD and frequent respiratory infections. So emphysema is one type of COPD, and it's defined by irreversible enlargement of the air spaces distal to the terminal bronchiole, accompanied by destruction of alveolar walls. The most common type is so-called centrilobular or centroacinar emphysema. This is the type that's mostly caused by smoking and biomass exposure as well. And so this is going to affect respiratory bronchioles in the proximal part of the acinus. It's going to spare the distal alveoli, and it's more common and pronounced in the upper lobes, especially the apex. Panacinar emphysema is much less common. It's usually caused by alpha-1 antitrypsin deficiency, and in this case, the acini are uniformly enlarged from the respiratory bronchioles to the terminal alveoli, and it's going to occur more commonly in the lower zones and be more severe at the bases. So here's a nice picture in Robbins showing the two different types of emphysema. The centroacinar is in panel B there, and it shows you that it involves the proximal part of the acinus, the respiratory bronchioles, whereas the panacinar is going to involve the entire part of the small airways with the alveolus and alveolar duct involved. So when you inhale cigarette smoke and other noxious particles, it's going to damage the respiratory epithelium and cause inflammation, and that's going to lead to resident epithelial cells and macrophages releasing inflammatory mediators like cytokines that attract neutrophils and other inflammatory cells that then release proteases that break down connective tissue like elastin. And in individuals who have fewer antiproteases like alpha-1 antitrypsin, they're going to have more digestion of that elastic tissue. And normally small airways are held open by elastic recoil from the lung parenchyma. When you lose that elastic tissue, you're going to lose radial traction that keeps those small airways open. So that's going to lead to collapse of respiratory bronchioles during expiration, and that leads to airflow obstruction. All right, so this picture just shows that with a normal airway, you have lots of elastic tissue giving radial traction to keep that airway open. Whereas with emphysema, you're going to lose that elastic tissue, and so you're going to have less radial traction. The airway is going to shrink. You're going to have a smaller radius. And we remember with Poiseuille's law that if you have a smaller radius, you're going to have more resistance. Man, that guy just keeps coming back. And with Ohm's law, an increase in resistance is going to result in a decrease in airflow. All right, let's talk about something called the equal pressure point. This is the point along the airway during forced exhalation where the pressure inside the airway equals the pressure outside, so that's the pleural pressure. And if the pleural pressure exceeds the airway pressure, the airway can collapse, but normally the equal pressure point is in the larger airways, which have cartilage to keep them open. With emphysema, you have loss of that elastic recoil and reduced radial traction, keeping the small airways open. That loss of elastic recoil means less driving pressure for pushing air out. And pressure inside the airway drops more quickly along its length, leading to the equal pressure point shifting distally to the smaller airways that don't have cartilage to keep them open. So if the pleural pressure exceeds the airway pressure, as it will during forced expiration, the airway will collapse at that equal pressure point and the air will get trapped in the lungs. So this is why patients with emphysema often breathe through pursed lips. They're trying to increase the airway pressure, and shift the equal pressure point more proximally to prevent airway collapse. Why does emphysema cause hypoxemia? You guys remember that with emphysema, you have destruction of the alveolar capillary units, which is where gas exchange happens. So you're losing a lot of the surface area needed for diffusion of oxygen. And Fick's law of diffusion says that diffusion is directly proportional to surface area. So if you're losing that surface area, you're not going to have as much gas exchange. Now, not everyone with emphysema will have hypoxemia. And that's why the classic phenotype for emphysema is the pink puffer, where they're not cyanotic, but they are working really hard to breathe. The other major type of COPD is chronic bronchitis. This is defined as a persistent cough with sputum production for at least 3 months in at least 2 consecutive years, not explained by any other cause. And so what happens with tobacco smoke and other noxious substances, when you inhale them, it's going to stimulate goblet cell hyperplasia in the small bronchi and bronchioles, and that results in hypersecretion of mucus, and that's going to plug up the airways. The tobacco smoke also interferes with the normal ciliary action of the respiratory epithelium, so you can't clear the mucus. And this is going to lead to chronic inflammation that causes structural changes and narrowing of the small airways, and that's going to increase resistance to airflow during expiration. So with chronic bronchitis, you're going to have hyperemia and swelling of the mucous membranes with excessive mucus production. You're going to have chronic inflammation of the airways with lymphocytes and macrophages, thickening of the bronchiolar wall due to muscle hypertrophy, and deposition of extracellular matrix in that muscle layer, which leads to peribronchial fibrosis. You also have enlargement of the goblet cells and mucus secreting glands of the trachea and the bronchi. Now, why does chronic bronchitis cause hypoxemia? It's different than emphysema. This is because of low VQ ratios, so VQ mismatch. When you have excessive mucus filling the small airways, it's going to prevent ventilation of those alveoli, so you get the low VQ. And so chronic bronchitis patients are actually more likely to have hypoxemia than emphysema. That's why they're called the blue bloaters. So the blue is that because they're cyanotic. The bloaters is because they're more likely to develop pulmonary hypertension. So with all that hypoxemia, you get pulmonary vasoconstriction, which eventually leads to remodeling and pulmonary hypertension, and that causes right heart failure. So then they start developing edema, ascites, etc. That's why they're called bloaters. Why does COPD cause hypercarbia? This can be true in both chronic bronchitis and emphysema phenotypes. They just can't get the air out, so they have that air trapping and hyperinflation, and they have increased dead space, so areas of high ventilation with low perfusion, and that's because they've lost some of those alveolar capillary units. You're not getting good gas exchange there. You can get air in, but then you're not able to get the CO2 out. So the classic clinical presentation for COPD is going to be chronic dyspnea that gets worse over time, worse with activity, and it's persistent. It just never gets better. A lot of patients will have cough with or without sputum production, and some patients might also report wheezing, chest tightness, and as the disease progresses, you get more fatigue, activity limitation, and signs of wasting like weight loss, cachexia, anorexia. Now, obviously, COPD isn't the only thing that can cause chronic cough, and so especially if you're entertaining a diagnosis of chronic bronchitis, you want to make sure you're ruling out other causes of cough, and so keeping a broad differential, think about asthma, cancer, infections, heart failure, those types of things, as well as your common causes of cough like postnasal drip and allergies and GERD. Don't forget your medications like ACE inhibitors. As far as physical exam findings for COPD, there aren't really any sensitive exam findings that show up early in the disease. Most of the classic exam findings are really found in late COPD, so that pursed lip breathing, prolonged expiratory phase, and expiratory wheezes. They may have decreased breath sounds, hyperresonance to percussion because of all the air trapping. You might see them using accessory muscles like their intercostals or the sternocleidomastoid. And some patients will develop a barrel chest where they have that increased anterior posterior diameter because of the air trapping. With advanced COPD, you might see signs of right heart failure, or also called cor pulmonale. And then those late stages, you'll see the cachexia and muscle wasting. All right, so to diagnose COPD, you have to do spirometry, and you're looking for obstruction on spirometry, which is defined as an FEV1 over FVC ratio of less than zero point 0.7. Now, using this fixed ratio may result in overdiagnosis in elderly patients and underdiagnosis in young adults. So, some people recommend using the lower limit of normal, which is based on a normal distribution and defines the bottom 5% as abnormal, or you can use Z scores, which are the number of standard deviations below the mean value of what you're measuring. The GOLD guidelines recommend using the fixed ratio of zero point 0.7 because it's simple, it's consistent, it's easy to remember. That's what I use. But you probably will meet pulmonologists who prefer the lower limit of normal or the Z scores. Patients can have structural lung disease like emphysema on a CAT scan or other physiologic abnormalities without obstruction on spirometry. So you would call those patients pre-COPD. So here's a time volume curve from a spirometry. On the left, you see what a normal tracing would look like, where you have a pretty big FEV1. You're able to exhale a lot and plateau pretty quickly with your forced vital capacity, whereas on B, you see that the FEV1 is significantly reduced, not able to get a lot of air out quickly in that first second, and it takes longer to plateau to that forced vital capacity. So once you've confirmed that they have obstruction on spirometry, the GOLD guidelines recommend also grading how severe it is, and that's based on your FEV1. So you can have a normal FEV1, and that would be mild obstruction, all the way down to FEV1 less than 30% of predicted. That would be very severe obstruction. There are standardized dyspnea scales that you can use to grade how severe your patient's symptoms are. So there's the MRC dyspnea scale and the chronic airways assessment test. These are things that you can do to track your patient's symptoms over time, and they also help you determine how severe the symptoms are, and that can help you pick the right therapies. All right, so once you have the diagnosis, you have that ratio less than zero point 0.7, you know how severe the obstruction is based on the FEV1. The next thing is to categorize your patient based on their exacerbation history and their symptoms. So if they've had one or more moderate or severe exacerbation in the previous year, and that usually means they've been hospitalized, then you would put them in the E category, exacerbation. If they haven't had any exacerbations, then you're going to categorize them based off of their symptoms. So if they have very mild symptoms on those dyspnea scales, you put them in the A category. If they have severe symptoms based on the dyspnea scale, you put them in the B category. And this is important because this is how you decide what treatment to put people on. So if they have no exacerbations and they have mild symptoms, they're a group A person. It doesn't matter what you put them on. You can pick any bronchodilator, pick a LAMA, pick a LABA, whatever you want. If they are in that group B, where they have not had any exacerbations, but they have pretty severe symptoms, you want to get them on a LABA and a LAMA. If they're in group E, which means they have been having exacerbations, they also should be on a LABA and a LAMA. And then you have to consider if they might also benefit from an inhaled corticosteroid. So your long-acting beta agonists are drugs like salmeterol, formoterol. You might see other ones though like olodaterol and vilanterol. You notice that they all end in -erol. So if you see a drug like that, it's probably a beta agonist. These medications work by stimulating the beta 2 receptors in the airway, which leads to bronchodilation. So you increase the radius of those airways, it's going to decrease resistance, and you're able to get more air out. Side effects of beta agonists are going to be tremor, tachycardia, palpitations, and they might feel nervous or jittery. That's because you're stimulating those beta 2 receptors, and it might have some off-target beta 1 receptor stimulation as well. Next, we have the long-acting muscarinic antagonists, or LAMAs. These drugs include tiotropium, which is the most common one and probably the one you'll see on board exams, but you might also see umeclidinium and glycopyrrolate, especially in combination inhalers. These medications block muscarinic 3 receptors in the airways, which leads to bronchodilation. And the main side effects are going to be related to anticholinergic toxicities. So, dry mouth is very common. And if they have systemic absorption, they might have constipation, urinary retention, or blurred vision. Next, we have the inhaled corticosteroids. That's going to be drugs like fluticasone and budesonide. Those are your most common ones. These medications suppress the production of cytokines, prostaglandins, leukotrienes, and they'll suppress eosinophils, and that's going to decrease inflammation, edema, and mucus production in the airway. The main side effects are going to be thrush or oral candidiasis, some hoarseness or dysphonia, and especially in patients with COPD, there's an increased risk of pneumonia. So, not every patient with COPD should receive inhaled corticosteroids, which is different from your patients with asthma, where it's really the backbone of therapy. With COPD, you have to be more selective because of that risk of pneumonia. And then there is some risk for systemic absorption of the steroids if the dose is high or they're on it for a long time. So, how do you decide if your patient needs an inhaled corticosteroid? Probably the biggest thing is going to be how often they're having exacerbations. There is good evidence that inhaled corticosteroids will reduce exacerbations. So, if they're getting hospitalized for exacerbations or having more than 2 moderate exacerbations per year, then they should definitely be on an inhaled corticosteroid. There's also evidence from the trials in subgroup analyses that patients with an eosinophil count over 300 benefited more from inhaled corticosteroids. The guidelines call that out and say, hey, if your patient's eosinophil count is high, they probably would benefit. And then also, if you have a patient with a COPD asthma overlap syndrome, then they should be on inhaled corticosteroid. If the patient's having repeated pneumonia events, they have low eosinophil counts, or a history of mycobacterial infection, you should not use inhaled corticosteroids. It's important that you recommend non pharmacologic treatments for COPD as well. So, smoking cessation has the biggest impact. If your patient is still smoking, you should assess if they're ready to quit and give them whatever help they need, if it's nicotine, varenicline, whatever. Patients with COPD are very high risk for respiratory infections, so make sure they're up to date on all their vaccines. Physical activity is really important because patients are limited by their dyspnea. They often become more sedentary, and that's associated with worse outcomes. So it's important that they try to do something active every day. Patients who are hospitalized with exacerbations will also benefit from pulmonary rehab. And then patients who have hypoxemia should be treated with supplemental oxygen because that helps prevent that hypoxic vasoconstriction that leads to pulmonary hypertension, right heart failure. Oxygen is a vasodilator, so if they are hypoxemic, you should prescribe them supplemental oxygen. Here is a nice chart from the GOLD guidelines that summarizes the evidence for treatments that actually reduce mortality in patients with COPD. So you can see that as far as pharmacotherapy goes, the triple therapy has been shown to reduce mortality in patients who have frequent or severe exacerbations. But it's really the non-pharmacological therapies that have the biggest impact on mortality. So smoking cessation has a big impact, pulmonary rehab, long-term oxygen therapy. And then in patients who have hypercarbia or hypercapnia, they benefit from non-invasive positive pressure ventilation like bilevel or BiPAP. And then patients who have large blebs or upper lobe emphysema may benefit from lung volume reduction surgery. All right, let's talk about COPD exacerbations. This is the technical definition of an exacerbation, but basically it's going to be an increase in dyspnea, cough, or sputum production over an acute time frame less than 14 days, and it's associated with increased inflammation in the airway from an infection or pollution or other insult to the airways. And if you think your patient has a COPD exacerbation, you can grade how severe that exacerbation is, and it's mostly going to be based off of their vital signs. And so if they have pretty normal vital signs, you'd call that a mild exacerbation. If they have tachypnea, tachycardia, or hypoxemia, then they're going to fit into that moderate category. And then if you get a blood gas that shows hypercapnia, with PaCO2 over 45 and a pH less than 7.35, you would put them in the severe exacerbation category. Now, just because your patient has COPD and they're having more dyspnea doesn't mean it's always a COPD exacerbation. There can be a lot of other things that cause dyspnea that you need to think about, like pneumonia, like heart failure, acute coronary syndrome, pulmonary embolism, and those are all things that you should evaluate them for, based on how severe their symptoms are. All right, so the treatment of COPD exacerbations, we're going to use short-acting bronchodilators like albuterol, which is a short-acting beta agonist, and ipratropium, which is a short-acting muscarinic antagonist. And you can give those with inhalers or as nebulized treatment. If they're using a long-acting bronchodilator at home, you can continue that in the hospital, and you should prescribe it at discharge if they're not already on one. Systemic glucocorticoids like prednisone are very important for treatment of COPD exacerbations. We used to give long courses of steroids, but then the reduced trial in 2013 showed that 5 days was just as good as 14 days. And so then, basically from that point on, we've basically stuck with the 5-day treatment of prednisone. Antibiotics is always the big question with COPD exacerbations. The guidelines recommend that you do them if they have purulent sputum or a positive sputum culture, and definitely if they have a severe exacerbation and they're on mechanical ventilation, you should give them antibiotics. But you always have to consider the risks of antibiotics, the side effects. You might increase their exposure to resistant organisms. You might, give them a Clostridium difficile infection. And so, if you are going to pick antibiotics, try to pick one that's going to have the least collateral damage. The guidelines recommend all sorts of antibiotics. I think that macrolides and tetracyclines are probably your safest option. In patients with COPD exacerbations who do have respiratory acidosis or they're working really hard to breathe, you should treat them with non-invasive mechanical ventilation. So that would be like BiPAP. That's going to reduce the amount of work they have to do. It's going to give them some inspiratory pressure so that they can ventilate better and get rid of more carbon dioxide. For patients who can't tolerate that non-invasive mechanical ventilation, or patients who have altered mental status, or lots of secretions, or they're hemodynamically unstable, then you should intubate them and put them on mechanical ventilation. All right, that's it for this video. Hopefully after watching that, you're feeling more confident about diagnosing COPD, choosing therapies for COPD, and managing COPD exacerbations. Thank you for your attention.